So next unit topic is burns. It's V8. 25-year-old man is rescued from a house fire and taken to the ED department. How would you assess him? So I would approach the patient with ATLS protocol. I will ask before patient is arrived. I will send the crash or trauma bleep to the plastic surgeon, anesthetist, and all the trauma team in the ED. And then we will start assessing his airway and breathing, assess for any evidence of inhalational injury in his nose or in the mouth, any singeing of nostril or facial hairs, erythema, swelling within the mouth, carbon deposits or carbonaceous sputum, stridor, hoarseness, carbon monoxide more than 10%. And if there is possibility of traumatic injury to the neck, I should look after the neck with the cervical spine, give high flow oxygen, and measure ABGs and carboxyhemoglobin levels. If there is suggestion of inhalation injury, intubate to protect the airway and transfer to specialist general center. Early intubation is essential because later on oropharyngeal edema will make it difficult and could be fatal. All patients with airway injury should be managed in a regional center. Next will be circulation. So I will establish two large bowel IV canals in the endocubital fossa. Sometimes patient needs cut down, and then a urinary catheter will provide means of monitoring the effectiveness of fluid cessation. Then stop the burning process, remove all the cloths, and keep the patient warm to maintain core temperature and prevent hypothermia. Cool any areas where the burn process may still be ongoing, and simple cling film can be applied. How much fluid would you give to the patient with the major burns? So, for calculating the fluid, we need to see the depth of the burn. First, assess the depth and size of the burn wounds, and then we need to calculate the fluid. So, the type of burns, a major burn that requires fluid cessation defined as an adult. In an adult, is there being a burn wound more than 15% of total body surface area, or in a child more than 10%. And the types of burn depth assessment, if it's only erythema, it represents inflammation in the skin with no necrosis. First one is superficial partial thickness burn. This appears to be blistering of the skin with separation of epidermis from the dermis. And then is a deep partial thickness burn. In addition to the epidermal blistering, there is a necrosis of the variable depth of the dermis. This has the appearance of fixed staining of the dermis. So superficial partial burn, deep partial thickness burn, and then a full thickness burn. The full thickness burn will result in the firm and leathery feel, and looks like abdomen and dermis both are burned and charred. Size assessment, Lund and Browser chart for the children, and Wallace rule of 9, in which we get head and neck 9, upper limb 9, lower limb 9. In front of torso 18, back of torso 18, right lower limb, left lower limb 18, and one perineum. Then the for fluid we need to use the Parkland formula, which is 4 multiply weight of the patient multiply total body surface area, and the first half of the fluid is given in the first 8 hours and second half in the next 16 hours, and the time is calculated from the time of the burn. Patient has circumferential burn in his upper limbs. What would you do? There should be a rapid assessment of the hand to confirm the adequate perfusion and stability. If there is a concern, the patient will require an urgent escharotomy. So you need two parallel incision around the radial and ulnar border from in the forearm and the arm. Please look after the ulnar and radial neurovascular bundles. It could be done in ED, it could be in the theater in the sterile condition. What is the pathophysiology of the burn injury? So burn has three zones: Jackson zone, uh, because the protein denatures occurs at temperature above 42 degree, and permanent cell death occurs at temperature above 45. So first of all happen the zone of coagulation, which is in the center, then is the zone of stasis, then is the zone of hyperemia. And systemically it can affect any system. So first of all is the respiratory system, in which patient can have ARDS, and this is due to either the systemic inflammatory response, or it could be due to the direct lung injury from inhalation smoke and fumes. Cardiovascular, because the fluid shifts from the intravascular extravascular shifts because of the leaky permeabilities vessel in the capillaries. So we have to maintain the blood flow to the major organs, and peripheral and splenic vasoconstriction occurs and cardiac output decrease. Loss of essential function of the skin, which give us protection, regulation, and sensation. This will result in insensible heat and fluid loss, poor temperature regulation, and can allow bacterial translocation through the burn area. Metabolic, manifold increase in the basal metabolic rate and protein catabolism because of the decreased subcutaneous blood flow. Early enteral feeding is important. Immune system, becomes downregulated, increasingly susceptible to wound and systemic infection. When would you transfer a patient to a regional burn center? So it depends. Burn size of the burn. Large burns require fluid resuscitation. Depth of the burn, large areas of full thickness burn and inhalational burns. Burns to the special anatomical sites like face, hands, feet, genitalia or perineum, and circumferential limb burns. Patient factors: extreme of age, children or old age, patient with multiple injuries, patient with multiple comorbidities, or vulnerable adults. And if someone has chemical burns or electrical burns, and other concerning features are the unwell child following burn, and suspicion of non-accidental injury, and burn that are not healed at 2 weeks. Thank you.